Thank you very much. Right, so let's get into the meat of the meeting. I'd like to thank you all for coming out tonight. An excellent turnout, very pleased. I just want to make sure that we all are in the right room. We're here today to discuss the future of healthcare in West, North and East Cumbria. And for those who haven't read the document, in the back of it is all the details of how you can take part in the consultation, from completing a form to completing comments on the website and actually writing in. And on that note, before I introduce myself, I just need to enter into the evidence. We were provided a submission for people that couldn't attend, Mike Povey and Jeanette Thorley, who've given us some comprehensive points, which will be taken on board within the consultation. Okay, all of that done. My name's Andy Wright. My role today is to be the independent chair. That's very important. I don't work for the NHS. I'm completely independent of the consultation, and I don't live in the area, so I have no stake in this at all. Yeah, I'm employed by the Consultation Institute, and my role is as the independent chair to ensure that everybody has the fair say today. That's purely my role today, to make sure that everybody gets a say and everybody is heard. The question was, who am I, for those at the back that didn't hear it? Which brings me to the next point before I get into the meat of it. This is a very, very busy meeting. I'm really heartened to see so many people who've taken an interest in this. But I do need to ask for a couple of points. First, in terms of communications, for those people that that use hearing aids, there's an induction loop right the way around the hall, so you should be able to hear it. You should be able to pick that up. And we also have with us today a signer who will is also to assist those people hard of hearing. As we go through this, I'd ask you to keep your questions brief. And the reason for that is we've got a lot to get through today, and the time that you take is taking time potentially from other members of the audience to ask their questions. This whole proceeding is audio recorded, so you're aware of it, and it will be submitted as part of the evidence. So when you ask your questions, when we come to it after the presentation, when you ask your questions, please raise your hand to make me aware, and I will ensure that everybody gets a chance to speak. But wait until a microphone from our technical colleagues come along and give you the microphone and ask the question into that. And that's very important so that the panel can hear it, and also that the question is entered into the evidence so it can be considered in the final analysis of all of these findings today. And when you're doing that as well, I've been asked by technical colleagues, again, to ensure that we get all of the important questions across, that you keep the microphone close to your mouth so that we can hear. And again, most important question might be asked. If we don't hear it and it's not recorded, all we get are the responses, and it's difficult to understand the correlation between what was asked and what the response was. Okay, so those are the only ground rules for today. The other thing to say is that whilst keeping it brief, I respect everybody's right to free speech. So, and that includes the panel. So I would ask that we respect each other and that we allow people to finish what they have to say before they say it, and to keep things as clear and concise as we can. So that's what we're doing today. Without further ado, I'm going to hand you over to Stephen Childs, who will run us through a presentation. Once we finish that, I'll ask the panel to introduce themselves, and we'll hand over to you for questions and answers. So, yes, that's a good point, yeah. So there is a row of chairs free at the front. If people that are standing at the back want to come down here, you can come and sit down. Sorry? I'm going to get the panel to introduce themselves once the presentation is finished. I'll ask them to introduce themselves. Sorry? He will introduce himself now.
Good evening, everyone. My name is Stephen Childs, and I'm the Chief Executive of NHS Cumbria Clinical Commissioning Group. And although the success regime has been instrumental in supporting our community, our health and social care system, over the better part of the last year to come up with proposals for resolving some of the big challenges we face in West, North and East Cumbria, it is the responsibility of the Clinical Commissioning Group to oversee the consultation. So I will attempt over the next few slides to explain how that consultation process will be taken forward, and also to talk you through the proposals for meeting those healthcare challenges that we face. So first of all, just to repeat, NHS Cumbria Clinical Commissioning Group has the legal responsibility for leading on local consultations to changes in healthcare. But we do work very, very closely with a range of other NHS organisations and, of course, with the success regime itself. And my colleagues on the panel tonight represent those other health organisations, and they'll introduce themselves shortly. The outcome of the public consultation is incredibly important, but it's not the only consideration that the Clinical Commissioning Group needs to take into account. We need to look very carefully at the clinical considerations, financial considerations, and some of the practical considerations of the proposals before you, and suggestions for alternative proposals that come forward during the course of the consultation. I would also like to stress, and this is very, very important, that no decisions have been made. Nothing is predetermined. It's why we are spending so much time to engage with you and to listen to your thoughts, suggestions, and concerns. The responses that will be gathered in throughout and at the end of the consultation period will be independently assessed. So it won't be the Clinical Commissioning Group that looks at them in the first instance. It will be an independent organisation that draws together the hundreds and hundreds of responses and will then feed back to the CCG their independent assessment of the totality of the views. It's unlikely that any decisions will be made by the governing body of the Clinical Commissioning Group until the spring of next year. It's worth also just bearing in mind that whilst the consultation is not a vote, I think you know that, nor is it a referendum, it is a vitally important part of the decision-making process. So let me turn to the challenges that we face. Our population health in West, North and East Cumbria is not great. We have significant difficulty in attracting doctors, nurses, and other health professionals to work here. On average, compared to other parts of the country, we have too many people requiring admission to hospital, and they spend too long in hospital, and I think all of us would prefer to be at home rather than in a hospital in the first place. Overall, the reality is the NHS is overspent relative to the budget that it's given. And the CQC, that's the Care Quality Commission, the regulator that inspects healthcare services, tells us that some of our services are inadequate and some need improving. It's important also to point out that the changes that are being proposed are designed to ensure that we have clinically sustainable services for the future. These changes are not driven by financial considerations. The situation that we're facing has been with us, as you well know, for some considerable period of time. And of course, the longer that goes on, the greater becomes the uncertainty. We do need to have courage as we approach the changes that probably need to be made. And we need your help in making the right decisions. We believe we have a very compelling vision, and that is to create a centre of excellence for integrated health and social care provision in rural, remote and dispersed communities. We want a health and social care system that people want to come and work in and for and take pride in. One of the problems we have at the moment is we don't have that vision, and that in turn is making it so difficult to persuade people to come and work in the West, North and East Cumbria region. I want to just spend a couple of minutes explaining to you about the integrated care communities. Now, these are not part of the consultation process, but they are a really important underpinning feature of the future health and social care system that we envisage. It's not the first time that health and social care have tried to integrate, but it is becoming so vitally important. And the latest vision for how this would work is designing future services in the community around natural communities of 20 to 70,000 population. It's vitally important that the services that are currently provided to those communities are better integrated and coordinated and actually are given more responsibility for the resources at their disposal. That then means that as we provide more care in the community, rely less on the hospital sector, we can see a transfer of resource into that community. Ultimately, our aim is to ensure that more people remain independent for longer and we reduce the need for people to attend or stay in hospital. I beg your pardon. We believe that the combination of the integrated care communities and the changes that are proposed in the consultation documents, they are intended to deliver safer services of a higher quality that are clinically sustainable and financially sustainable. So let me turn to these potential service changes that we are consulting on. First of all, children's services. Now, the major problem we have currently with children's services is the difficulty we have in recruiting paediatric consultants. Across the two hospitals in West, North and East Cumbria, we have 5 consultant positions, but at the moment we have just over 1 consultant substantively employed. In other words, we rely on around about 4 locums at the moment. The service is regarded as being as good as the next locum that can be recruited. And this is not just a local problem, there's a national and international shortage of paediatricians. What we aspire to achieve is a whole systems children's service, more support in the community, fewer beds, because less children need to be admitted nowadays, more can be treated in the community, and that's in line with the advice of the Royal Colleges. So option 1 is for inpatient facilities at both Cumberland Infirmary and West Cumberland, but low risk only at night at West Cumberland, with short stay assessment at both Cumberland Infirmary and West Cumberland. The second option is for inpatients at Cumberland Infirmary with short stay assessment at both West Cumberland and Cumberland Infirmary. The third option is for full consolidation of children's services at Cumberland Infirmary with just paediatric outpatients at West Cumberland Hospital. And the preferred option is option number 1. Linked to paediatric services are maternity services, the linkage being the paediatricians. So long as we struggle to recruit paediatricians, we will find it increasingly difficult to provide safe maternity services, and that is a huge challenge at West Cumberland Hospital. We also have difficulty recruiting mid-grade obstetric doctors, which compounds the problem even further. So with all of the options, both antenatal and postnatal care will continue at both hospital sites. Option number 1 is for consultant-led maternity care to continue at Cumberland Infirmary and West Cumberland Hospital, but for high-risk births to take place and be managed at Cumberland Infirmary in Carlisle. The second option is for a midwife-led unit only at West Cumberland Hospital. The third option is for full consolidation of all maternity services at Cumberland Infirmary in Carlisle. And the preferred option is option 2. Turning to community hospital beds. The challenge, one of the challenges we face, is the significant difficulty we have recruiting enough nurses to work across the full range of community hospitals to ensure that we can provide safe care to all of the patients in those beds. We also have some infrastructure challenges with some of the hospitals and the ongoing cost of ensuring that those buildings remain fit for service. It's important to point out that none of the proposals consider closure of any of the community hospitals, so all of the community hospitals will remain open. But clearly there are implications for the beds across those hospitals. So let me just talk you through the options. Option 1 is for consolidation of the beds onto 6 hospital sites, and those 6 sites are Whitehaven, Cockermouth, Workington, Penrith, Brampton and Keswick. The second option is for consolidation onto 5 of the community hospital sites, so that option would see the closure of the beds at Workington. The third option, again consolidation on 5 hospital sites, would see the beds closed at Cockermouth. And the fourth option is for a consolidation onto 3 sites, which would be Whitehaven, Penrith and a new build community hospital at Carlisle. This, of course, would mean that the beds would close at Alston, Maryport and Wigton. And the preferred option is option 1.
Just ask the audience to hold your question till the end.
Turning to...
I'm sorry, I can't hear you. Okay, completely appreciate your point of view, sir. Absolutely valid. But please, I'd ask the audience to hold questions until the end so that I can hear them and we can get them entered to the evidence. And it's a valid point, but... Sorry, sir, can you wait until the end? I appreciate the passion, I really do.
Thank you. Turning to emergency and acute care, it's a priority to try and protect the concept of 24/7 accident and emergency care at both West Cumberland and Cumberland Infirmary. It's vital, though, that we make those services clinically sustainable, and we continue to have recruitment challenges, particularly at West Cumberland. The proposal is that we develop a new workforce that enables us to ensure those services are retained. A workforce that sees more skilled nurses and paramedics supporting accident and emergency services. So the options are, first of all, for continued 24/7 accident emergency services at West Cumberland and Cumberland Infirmary. The second option is for 24/7 urgent care centre and daytime A&E at West Cumberland Hospital. The third option is for 24/7 urgent care centre at West Cumberland with A&E at Cumberland Infirmary. Now, the preferred option is option 1, with that multi-skilled workforce at West Cumberland Hospital, supported, we understand, by the professional bodies and the clinical senates. Turning to hyperacute services, stroke services are simply not as good as they should be in West, North and East Cumberland. Neither of our main hospitals has a dedicated stroke unit, And we anticipate that the number of patients requiring care for stroke will increase from approximately 600 a year today to over 700 a year by 2021. And we are simply not meeting the quality standards that the Care Quality Commission expects of stroke services. On top of that, we are unable at the moment to recruit enough stroke specialists to serve both hospitals. With both of the options, rehabilitation services will continue at both Cumberland Infirmary and at West Cumberland Hospital. So the two options, to continue as present with 5-day-a-week stroke services, or alternatively, to create one dedicated hyperacute stroke service at the Cumberland Infirmary in Carlisle. Yes, that would be, yes, that's right, a 7-day service, sir. Yeah, thank you. So option 2 is the preferred option. I just want to share with you the financial context and to put into that context these proposals. So currently in West, North and East Cumbria, the NHS overspends in the region of £70 million a year. If we were to do nothing, that overspend would increase by 2020 to in excess of £160 million a year. We believe that we can make very significant inroads into that overspend by more efficient working and new ways of working. But the clinical changes associated with this consultation are only going to save us in the region of £2 million a year. Not insignificant, but as I said earlier, financial savings are not the driver for these changes. The driver is the safety of patients and the quality of care that we need to provide. Just turning to the future of West Cumberland Hospital, West Cumberland Hospital still remains a really important facility in the future of healthcare provision in North, West and East Cumbria. So we anticipate significant range of services returning to the hospital that are currently provided at Cumberland Infirmary in Carlisle. That includes some acute surgery, some trauma services returning, more planned or elective surgery returning, and a new diagnostic suite. Somewhere in the region of 7,000 contacts a year moving from Carlisle to Whitehaven to the West Cumberland. So more people will be treated at West Cumberland than are currently cared for. That concludes my presentation, Chair.
Thank you, Stephen. Right, I said to get the panel to introduce themselves. I'll do that now. I'll ask them each to introduce themselves on what their role is and what organisation they represent so that you can direct the questions. And for, just so the mic's aware, I asked the gentleman here to hold his questions until we'd finished. So I'd like the microphone there, please, for the first question. Okay, thank you. You just declined the microphone. Thank you. Sorry. Okay. So, yeah, please.
Hello, good evening. My name is Anna Stabler. I'm the Deputy Director of Nursing, Midwifery and Allied Health Professionals for the Acute Hospital Trust.
Hello, I'm Nick Strong. I'm a consultant ophthalmologist and I'm the Associate Medical Director at Carlisle. I was, until 2 years ago, in a sort of similar role in Newcastle, and I would be surprised if there weren't a patient or two of mine in the clinic present here who I've seen and treated in Hexham.
Hi, good evening. My name's Rick Shaw. I'm Service Development Manager for North West Ambulance Service.
Hello, I'm Dr. Craig Melrose. I'm the Associate Medical Director for the Community Services. I work for the Cumbria Partnership Trust, who is responsible for running the local community hospitals and also the community services such as the district nursing, physiotherapy and occupational therapy. I'm actually a GP. I currently practice in Carlisle, worked in Brampton and also for Cumbria Health on Call all over the county. So I'm very pleased to meet you all tonight.
Thanks very much. Take questions if you could indicate by your hand. There was a lady at the back. There. Yes, please. Thank you.
Thank you. I'm Alice Bondy. The last time we had a presentation from the success regime here, we were told that finance was the driving force. Today, you tell us it's not. Last time, you told us that PFI was irrelevant and wasn't included in the budget. I've checked that all out, and that is not true. It comes out of the hospital budget. Thirdly, we have already responded and been completely ignored. And fourthly, when you talk about costs, you completely fail to take account of any costs other than those that are specifically for the NHS. Given all these things that frankly are less than direct, honest and open, why are we meant to believe anything else you say?
Thank you for that series of questions. I'd like to ask the panel to respond. Who's going to?
So, as I said, I'm responding from the trust point of view, and I'd just like to answer the question around the PFI that you raised. The PFI currently costs the trust £6 million a year, but we actually get a reimbursement from the government of £6 million back into the budget at the hospital to cover that.
Thank you.
That I can't tell you off the top of my head, I'm sorry.
So we'll take the point about the interest and come back with that.
Just to add to that and repeat what I said earlier, the savings that will be achieved as a consequence of these changes, if the proposed changes are accepted, are relatively minor compared to the total financial pressure in the system. So I'm sure Sir Neil Mackay, when he presented to you as part of the engagement of the success regime, I'm sure he did talk about the financial pressures in the system that must be addressed. We still have that challenge. But the proposals before you tonight are not about addressing the potential 107, 160 million pound gap. There is a £2 million potential saving as a consequence. So these changes are not about addressing the big financial challenge in our health system.
Part of the question, I think, was just why I'd like you to explain the way the consultation process worked so the audience can understand why they should trust what's coming back, if you don't mind.
So I can only genuinely tell you that the Clinical Commissioning Group governing body has not made a decision. It genuinely is here to listen and to welcome variations on the proposals that have been submitted, because we do not pretend to have thought of everything. I've mentioned already that at the end of the consultation process, an independent assessor will pull together all of the responses and will submit their findings to the CCG governing body, and that will be taken into account alongside other considerations, so the views of clinicians, specialists, the views of other organisations, and of course the practical considerations too.
We've got two questions down at the front. Can we bring this lady and then this gentleman? So, here please. Okay. Could you stand? Sorry.
Sorry, yeah. Barnash Williams. I don't understand why, if no decisions have been made, the option of keeping any beds at our local hospital has been removed. It's no longer there. Why has it been taken off if that decision has not already been made?
Thank you. The proposals set out in the document are have come about following a period of the success regime and the organisations involved in running healthcare in Cumbria coming up with plans and proposals, and then we're testing them to see if they feel that they will be viable and whether they would actually work. And I think the hospitals that have been earmarked for having no beds, that has occurred for a variety of reasons. And in Alston, it's a reflection of the size of the unit and the difficulty in maintaining the nurse staffing of that unit. We recognise that units of 16 patients and above are more robust in terms of the way we can guarantee to be able to staff them, and run them. And when they get smaller than that, it becomes very difficult for us to ensure safe nurse staffing. So that's why we have suggested in this document, or it's suggested in this document, that the hospital should be built on multiples of 16 or patients and above. The guidance around safe staffing in a hospital is that one staff nurse should look after 8 patients. And that's why we've got the factors of 8 in terms of 16 beds in each unit. It was also recognised that Alston, when it was being considered, was a small unit, and that expanding Alston to 16 beds would be unlikely to be effective for the whole system, in terms of that there wouldn't be a large enough population in Alston as such to fill those 16 beds, and we wouldn't be able to use them effectively. Therefore, the decision was made that Alston probably wouldn't be viable as a small hospital, and to continue as it is. Other factors were considered around buildings, and they've been considered in other places such as Wickham, where the building was considered to be old and in need of quite a lot of work to be done, and that's what has led us to the conclusion that Wickham may not be suitable going forward. Having said that, this is a consultation process, and I must reinforce what Stephen said. No decision has been made, and we're actively talking to members of your community, including the League of Friends, about how we could go forward with a solution in Alston around providing care for patients in beds, but maybe doing it in a different way, perhaps doing something innovative in terms of the way that we collectively work together with social care and the community at large to deliver the care that people need in Alston, because we recognise it's a very remote location, and actually it's vital that the community has a central hub around which its care and services are located. It's also obvious that all of the services in Alston are relatively small and rely on each other, and that interdependency is very important in order for Alston to go forward and be a successful community, for us to deliver care successfully as part of the Eden ICC. As Alston falls into the Eden ICC, it's very important that we have viable services up here. And I think that for that reason, we're very keen to explore all the options that we can to make sure that Alston gets the facilities that it needs going forward to deliver care. If it's possible to do it, we will look at doing it.
Thank you. There's a gentleman here who's been waiting very patiently. I'll take his question.
Good evening. My name is Peter Kempsey. I'm an architect delivering professional services in Alston, which I have done since 1983. And I've watched the community hospital, used it, and honoured the service that's been given by this hospital. You're Craig Melrose, yes. You've exactly outlined the reasons why we need to keep our beds. We are the most remote community in Cumbria, and it's also one of the most disadvantaged communities. So in terms of car ownership, people who want to visit, people in terminal care, they face real difficulties. I've read the consultation document, and 2 things jump out at me, and they've been mentioned tonight. Difficulty in recruiting staff. Well, when we first moved to Whitehaven in 1973, there wasn't that issue. We joined Copeland Borough Council, but the health situation was one of relative stability. Can I suggest that it's all the sort of statements of special measures and that sort of thing that if I was a doctor, or a nurse, I'd be unwilling to come into a community like this, when it's been we call it bad-mouthing in Cumbria. I don't know if you've heard that expression, but it's so bad-mouthed. No wonder you have difficulty in recruiting staff. You need to uplift.
Okay. Sorry, I don't want to cut you off.
I've got one more point.
Okay,
one more point.
You.
The other is the obsession with budget. Why do you try and look at a service that has to fit a budget? Why don't you look at a service that we all should have and then fit a budget to it? It might not be what the government wants.
Thank you for those points, and let Anna take the first.
I'm just going to, can you hear me? I'm just going to pick up on the point on nurse staffing. We've actually just recently in the Acute Trust brought in a number of new nurses, and our actual vacancy rate across both hospitals is sitting at about 4%, which is actually fairly reasonable if I look at my compatriots across the rest of the North East. We also are not resting on our laurels on that. We've actually got a national advert going out in the Nursing Times in next week, I think it is. And we're actually working with the Cumbria Partnership to put a further advert out in 2 weeks' time to try and bring some other nurses in to work in the community hospitals. So what I would say is that we are still trying to bring nurses into the services, both in the acute hospitals and across the community services and the community hospitals. Within that, we are actually looking at giving golden hellos and extra remuneration to those people that want to come and work in our communities, because we recognise how important that is. And I'm going to pass on to Nick now to talk about the work that we're doing around the medics.
When I trained and then got appointed a consultant, there was tremendous competition for posts, and even when we were toward the end of our training, we were quite concerned about, would we get a job, would we end up being stuck as a senior registrar for ages, that sort of thing. There have been a lot of changes recently, and I have to say I've found it, coming from a teaching hospital where it's only just starting to have an impact, to come to a district general hospital and find quite how difficult it is to recruit staff. I could go on quite a long time. I don't think it would be helpful about various changes that have occurred in the NHS that have done this, and the number of people who, for instance, A&E doctors got hoovered up by Australia recently to large numbers and have made recruitment very difficult. But the bottom line is, it is phenomenally difficult to recruit, and one is spending a lot of time, repeatedly advertising and trying to appoint people. And the government have become aware of this. You notice there was an announcement a few weeks ago saying that they're going to increase the number of junior doctors. Well, that will take 10 years to set up the medical school, get the doctors in and through. So clearly we can't wait 10 years, and we've got to understand how we get through the next 10 years.
So can we just pick up the point about the budget as well, please?
Yeah, I was going to say, to pick up the point about the bad mouthing. Cumbria and Morn and Bread, I know exactly what you mean, and I think that you're absolutely right. If we talk our services down, we're not going to do ourselves any favours, and it's going to be harder to recruit. And I think we've seen that have an effect on recruitment, perhaps in the community hospitals, with the level of doubt that there is around their future. Brampton has recently put the Riga Friends have put a banner outside saying, now recruiting rather than save our hospital, and we've recruited to Brampton. It will make a difference. But I think the really key thing is that actually we go forward with a very positive future and vision for what we're going to do in our community hospitals, and seeing how they fit into the future of healthcare in the area. So if we've got a positive and very clear vision of where they're going, then it will be easy to recruit to those units, because they'll be vibrant places to work and they'll attract people. And I think that's really where I think I would like to see us get to, because I don't want us to come back around again, because we were here not very many years ago having the same conversation. As a Cumbrian, as a GP who works here, as somebody who will no doubt use the services going forward, I really, really want Cumbria's health services to move out of this perpetual cycle of uncertainty, which is actually harming us all. So this is why it's important to have the consultation. Now, in the consultation document, there are lots of suggestions and there are preferences, but that doesn't mean that there may not be some other solution that we haven't thought of. And I think it's very important that if the public, through the consultation process, come forward with other solutions, that they're listened to and they're considered. And that's what Stephen's given a pledge to do in his role at the CCG. I think it's vital that we do that, because we need the collective wisdom and also the collective ownership of the communities to actually help us solve the services in this county, because actually we're all involved here. It's all of our responsibility, not just the people who are in charge of running it.
I'll just pick up the gentleman's final point about why can't we fit the budget to the service. I think there isn't anyone in a senior position in the NHS that wouldn't want to try and do that. But the reality is, as a public department, Department of Health, it's actually illegal for it to overspend its budget. So that's the harsh reality of funding in public services, sir.
Okay, thank you. There's a lot of questions. There's some people who've been waiting very patiently. There's a gentleman in a brown jacket there. There's a lady with a green fleece that's been waiting. I'll come over to this side then, and I'll come back to here. Okay.
Well, my question has in fact been preempted by the previous questioner. However, I don't think you've answered the question, the burning question. A lot of blame is laid at the door of the issue of the difficulty of recruiting staff. But you haven't answered the question of why you think that is. The same could be asked of the £70 million overspend. Why would those things be the case?
I think we have difficulties recruiting medical staff because of the numbers of medical staff training were reduced a number of years ago. So that's compounded the number of juniors that have come out that can move into consultant roles. I think we're competing in Cumbria with big centres like Newcastle. You've got young, vibrant consultants wanting to come out and work in centres like Newcastle to get their experience. And until we can reconfigure our services potentially to make it more interesting for them so that they can pick up specialities, we've got to have something to offer them. And whilst we've got a lot to offer at the hospitals, at Whitehaven, we've got the partnership with the University of Central Lancashire, and we've got partnerships now moving forward with Newcastle, which I think will help. It has been compounded by years of the junior doctor reduction and not having enough doctors coming out at the other end.
Thank you. We could ask the lady with the... There. Yes, thank you.
Hi, thank you. In 2010, 2011, you came and did a consultancy and basically took away some of our beds and said you'd bring better services to the hospital. That really didn't happen. And here we are all over again. And if you take our beds from the hospital, that means that the nurse-led care will go because there is no need for the nurses to be there. And if the nurse-led care goes, that means that the GP surgery will go. And I'd quite like to ask the 10% of people in this room that represent Alston, how many people had something to do with the hospital or the doctor or work for the hospital or doctor today? Would you put your hands up? How many people actually had something to do with the NHS today? Just today. And this is 10%. How much will it cost you to bring all of those services that we get here, that we enjoy? How much will it cost you in the future if they go? It'll cost you an absolute fortune. So what that basically means when you say that 20k communities are the only ones you're prepared to bother about is that means that you are ignoring us, you are leaving us behind, and you are basically killing us. That's not fair. And what will happen when all these people in the room and further afield start taking the law against you?
Thank you. Wait. Yeah, okay. So, yeah.
Okay.
Could we keep the answers very concise, please?
Okay, brief.
The question was, could the speakers keep their responses concise, because we're only here for a limited time.
So just to respond to the point there about populations of 20 to 70,000, which is quoted in the document around ICCs. Integrated care communities will be of that size in terms of their total population, but in a population like the Eden ICC, there'll be small units within that larger ICC that will function as a greater whole. So the Alston area will have an element of the Eden ICC looking after it. So it won't be that you have to be a 20,000 population plus to actually receive a service. The service in the ICC, the integrated care community, will actually be delivered in a way that is bespoke to the area that it serves. So in Carlisle, for instance, I work in a practice in Carlisle. We are one practice, we've got 37,000 patients, we'll be one ICC. That's very straightforward. In Eden, there are lots of practices, lots of dispersed communities. There'll be lots of separate groups within that ICC that will deliver services, so some around Penrith, some around the Upper Eden area, some, etc. So it won't be that you wouldn't get a service just because you're not 70,000 in size. So does that reassure you?
Sorry, can we just get the mic to you so everyone else can hear you?
We already know that when you tender out services to Carlisle and Penrith, it takes an hour to get here, it takes an hour to get back. People only have, the workers only have an hour here. Yeah. This isn't cost effective. If it's not about money, you taking this away is utter madness.
Okay,
thank you.
Can I just respond to that?
No, a response.
So, I'll try and keep it brief. But the integrated care communities will, as they evolve and become proper substantial entities, will be responsible probably for running the services within their area and managing their own budget. Now, if they are working inefficiently and, say, requiring patients to travel or not delivering adequate services to those patients, that will then generate more cost to the ICC and actually will be not in the ICC's interest. So therefore, the ICC model should actually lead the local services around you to be incentivised in making sure that the services delivered here are effective and that they work. That's the thinking about bringing care into ICCs, which is closer to where the community actually is. And I think, we've had conversations around what the potential future and other options around this. And I think ensuring that we arrive at a solution that functions well and delivers the services for Alston is important. And I completely recognise this is a unique community in a unique place, and it does definitely need services that work for the community. And travelling up and down to Penrith or to Carlisle for everything is absolutely not something that's an option. So.
Thanks very much. There's a lady in green here who's been waiting very patiently. So I'll just get the mic to you, and I'll come back.
Thank you. I got this proposal today, and I've read it, and the thing that sort of struck me most was how unimaginative your options were. They're completely unimaginative. It's closure, 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 closure. And also reading through it, the big thing seems to be recruitment, retention, skill mix, cover for sickness, and also the budget, because you want to budget for 1 nurse to 8 patients. Now, looking at it, to me, there's a very simple 5th option. Increase Alston beds to 8. Increase Brampton beds to 16. Decrease your Penrith beds, as you say, down to 24. Share the nurses out between the 3 units. Move your nurses, move your staff, don't move your sick patients and the relatives who need to travel. The other thing that's really not acknowledged in this document is how unique Alston is geographically. We are impossible to get to in the winter. I feel very sorry for the other hospitals that are for closure as well, but they don't have the same issues as us. They don't have the lack of transport. They don't have Hartside Pass to negotiate. If Hartside's closed and we have a relative who's in Penrith, that is a phenomenal journey. I know, I've had to do it in the past. I've had to do it for a week when I've had a sick relative in Penrith. I know exactly what it's like. Use your imagination. Let's be more creative. Why aren't we growing our own staff within Alston? Why aren't we recruiting nurses from within Alston, from the actual teenagers that are coming through in this school, and then encouraging them to stay in the hospital? What is happening about that? And you gave us a very good excuse or very good explanation for why the doctors are a problem for recruitment, but no explanation for why nurses are a problem for recruitment. And, this...
Yeah, I can feel that this is a very important issue to you. I'd like to... I'm not trying to cut you off.
It is, but we are, looking at this is incredibly unimaginative.
Okay, so I take your point. So we're looking for... more imagination, and I'd like to throw that to the panel. Who do I take first?
So with regard to the work that we're doing around nursing recruitment, both the Acute Trust and the Partnership Trust are working hard to recruit locally from within the county and within specific communities. I'm sure you're all aware there's a new apprenticeship scheme that's going to be starting in April, and we're working very closely with our schools to try and encourage our young people into those apprenticeships, but working in partnership with the local university at Carlisle as well, so that when they've gone through these apprenticeship programs, they can then access their nurse training directly on, because they'll have the requisite qualifications. We've developed some innovative new posts for our health cares, and they are training with the University of Lancashire Central Lancashire up to assistant practitioner status, which is a foundation degree, which is a step up from a healthcare assistant. These are both in the acute and community services. and there is going to be a step-on programme for them when they have finished that training into registered nursing and completing that with the University of Cumbria. So these processes are all underway. Again, there was a commissioning cut by the government on nurse training a number of years ago, which has impacted on the number of nurses coming out of training. And what I would say, it has been further compounded by the removal of the bursary from the university training. Now, unfortunately, that was a central government decision, and what we are waiting to see is the impact of that, of what that has on the applications into nursing now. So, do you feel I've answered your question, or would you like to come?
I think in the short term, as far as Alston's concerned, you know, you've had a problem with recruitment, but you have got two hospitals, Penrith and Brampton, within drivable reach for the nurses. So why not just rotate the nurses round between Penrith and between Brampton? And so if there's sickness, which is the issue, then take it from Brampton.
So I'd just like to let Craig respond to that.
Yeah, well, we do encourage the nurses to move when it's possible for them to do so, but it's not always possible. They work in places for a reason and don't always necessarily have the means to get to Alston. If they work in Brampton or Penrith, it's not guaranteed. But they do move. They do move, and the nursing staff, the nursing staff in our organisation are absolutely fantastic, and they've bent over backwards to make sure that the units have stayed open. We reached a crunch point in the summer, as everybody in the room will know, where actually we got a 60%, 70% gap in our staffing rota that we literally could not fill. And that is the problem. We're very vulnerable. We recruited 2 nurses. We've filled the rota to enough of an extent now to reopen the unit and for it to be running. But I do know that 2 of the nurses there are doing 50-hour weeks to make up the gaps because we've still got a full-time gap in the rota. Now, we know from experience that actually nurses who come to work at Alston tend to stay at Alston if they live somewhere nearby, but they don't tend to stay if they get another offer in a job somewhere else where it's nearer to where they live. It's just the nature of the way we all are. I completely agree. We need to attract people. We really need to get local, people who are interested in nursing to have a nursing career and stay locally, because that's how it always used to work, isn't it? The degree course for nursing, etc., has maybe not helped us where that's concerned in Cumbria.
But make it a contractual thing that if somebody's working in Penrith and the cover needs to be in Alston, that is part of the contract. And then you're providing a much more robust service for all 3 hospitals. Yeah. And you're saving costs because you're actually maximising your nursing to your bed ratio.
Yeah, I agree. I mean, I think that you're right. That when we had the crisis in the summer, that was something we did talk about actually introducing for the future in terms of making it sort of networking hospitals together so that actually we're more robust. And actually, if hospitals are functioning as part of their local communities as well, we have had support from community nurses coming into the hospitals and working shifts in hospitals as well. And we've got a bank system going on where we've got banks of nurses who will come in and fill gaps, who are local nurses and who are willing to step up when we're short. So, we do have a lot of local nursing support into the units already. The teams are great and they're really, really committed to their own communities. And the Alston nursing team, is absolutely fantastic in the level of commitment that they've shown to keeping their units open. They deserve a round of applause, really. They're absolutely fantastic. So,
sorry, can we just keep the comments till we get the microphone, because people can't hear what's being said. And
One final point in terms of your comment around the imaginativeness of the proposals. The proposals are what they are, but we're very keen to hear from the local community about other proposals, and that's a conversation that we're having with the League of Friends and some of the other members of the community at the moment to explore what else is that we could do.
Other than close the beds.
Other than lose the option of having beds in the area, yeah, whatever shape or form they take.
Thank you.
Right, sorry, aerobic workout for our technical friends. And there's a gentleman here who's been waiting very patiently since the beginning of the meeting.
Hello, I have a very simple question actually. How much does it cost annual to run Alston Hospital, and by closing 6 beds, what would that do to the cost?
Good question, I'll find out. Claire, do you know?
Detailed technical question.
I'll come back to you on that one. I don't want to give you the wrong figure. come back at the end, then.
Okay, so we have a commitment from the panel that they will come back before we leave with that response. Okay, thank you. So, did you want to make your comments? Yeah. Yes. I've got a lot of hands up, and I'm trying to get to people in order. Yes, here, please. Sorry.
Right, I've got a microphone now. I'm sorry for shouting out, but there's a reason, you know. Answer your questions with pleasure, but answer them quickly so that we can get everyone else in, because we're all stuck in here. Now, one of the reasons your recruitment's so bad, and you won't like what I'm going to say, is because Carlisle has been bad. The reputation of Carlisle Infirmary has been terrible for years. It actually seems as if it might be improving. So don't say it's the doctors or the nurses. It's you, it's the people that run the place. Make it exciting. Make it like Newcastle hospitals are. Make it like where most people now go, most likely, is Hexham. It's fantastic. You like going there because you're on time, they see to you straight away, and it's work. And they don't have problems with people. You want to listen to what people are saying. And will you answer, you especially, the questions?
Thank you.
So can I just come back on the nursing at the acute hospital again? I think I've already said earlier, I would say our recruitment vacancy factor is only 4%. That is tiny. We have only got, I think, off the top of my head, about 35 vacancies in nursing. That is not large. Newcastle have got around about 260 vacancies.
Sorry, I'll help you out. So everyone can hear you, I'll bring it to you. Yes.
Yeah, Hexham, someone's just said to me. The truth is that it's great there. You make an appointment, or they make an appointment, you arrive on time, and you're seen within 5 minutes. 10 at the most. It really is like that. Come on, Carlisle, you're way behind the majority.
That's all right. Everyone's got the right to free speech. Make it exciting.
I moved from Newcastle to Carlisle 2 years ago because I was asked to go and help. Now, I did move from one environment to a very different environment. And in Carlisle, there is a very long history of underinvestment. There have been multiple changes of management, which never gave for any form of continuity. So I found myself coming from a situation where I could happily find a clinic letter that I wrote 15 years ago in a few seconds, to having my notes there and so forth, to having badly organized notes and various other deficiencies. Now, those are recognized, but once you've recognized them, you can't turn it around just overnight. And we've been doing a lot, sometimes things that aren't popular. We centralized the medical records in a big building so that we had enough room so that, one of the problems why you couldn't find the records was the building was too small and they started getting stuffed in any corner you could find. And so we moved into a bigger building, but people, there's always somebody who thinks that's a bad idea. Now the records availability is much better. Getting patients seen on time, you always have a compromise between whether you see the patients exactly on time, and as I said earlier, a few of you have been in my eye clinic, and I've seen 40 patients in an afternoon, and you get a few difficult ones, then people get held up. On the other hand, I could have seen 20, and then you'd all have got seen on time, but you'd have waited 6 months to be seen. So there are a lot of compromises that one has to make, but overall, the intent is to try to progress. And that is what we're trying to do. And I think we have made a lot of progress over the last couple of years.
Thank you. Any other? All right, okay. I'm going to take a question from the gentleman there who's been waiting very patiently, and then come to this lady. And then we've got some questions at the back here that I will come to, and I'll come back to you here. I just want to make sure, and this lady at the front as well, make sure everybody gets the chance to speak.
Thank you. Hello, I'm David Morant. I have been a Director for Nursing and Clinical Services at the Cumberland Infirmary, also at Whitehaven Hospital, and also I've managed community services of the community hospitals in the community here in Cumbria. So I've had quite a bit of experience of providing health services in a rural community. I want to really concentrate on, I know nurse recruitment and I know finance are important, but I want to concentrate on two particular aspects: safe services. At the moment, we've got community hospitals with a registered nurse on duty and a care assistant at all times. The proposal is to move patients into care at home. Now, at the moment, most patients, yes, want to be at home, but there are a group of patients who are not sufficiently ill to be at the Cumberland Infirmary or West Cumberland Hospital, but too ill to be at home. So let's think of what's going to happen to this group of patients. At the moment, they are to be cared for at home, bearing in mind that social services have not been greatly involved in these discussions, and the recent leader of the county council has said that he is doubtful as to whether he will be able to provide the resources for care at home. What will happen at 2 o'clock and 3 o'clock in the morning when one of these patients who are at home either falls out of bed or has some pain or is sick or whatever? If they were in hospital, a nurse would attend to them immediately. If they're at home, then I doubt whether the new service will be provided at 2 o'clock and 3 o'clock in the morning. Now, you say that the most important drivers of your recommendations are safe services. I have serious doubt as to whether the services at home will be as safe as those currently in hospital.
Well-made point, very well received. Could I just ask a question, though? You mentioned that your role. Are you asking this question as a professional or a resident? Just for clarity.
I'm asking the question. Is this working?
Yes, it is.
I'm asking the question as a resident. I don't live in Alston, I live in Brampton. But I'm equally concerned for the people in this community as those in Brampton and anywhere else in Cumbria.
Thank you very much.
Thank you for the question, David. You're right, safety is paramount, and one of the things that we're trying to do going forward is to improve the safety of services in Cumbria as a whole, to improve the quality of care that people receive as a whole. We do know that you can successfully look after patients at home if you have the right services around them and the right support. So we've got in Carlisle at the moment, there's a hospital at home service which was set up following the Yeah, let me finish. In the hospital, was set up on the closure of Riva House, and that functions very well in that environment. And I think, in an urban environment when it's easy to get to patients relatively quickly and they're accessible, there are quite high levels of dependency that can be managed in a patient's home environment, and patients prefer it. And actually, hospitals, we think of them as being safe, but they are actually risky environments in terms of you're exposed to the risk of infections, people fall, people hurt themselves, and actually. If you spend long enough in a hospital bed, it deteriorates. If an 80-year-old patient spends 10 days in a hospital bed, they'll lose 10 years of muscle mass.
Sorry, if I could just call the audience to order, please. Allow the response to be heard properly, and then I will give you your turn to question back.
People do function better at home, and they get fitter at home because they're able to move about and look after themselves and do their own thing. So. Having said that, we do recognise that in rural areas, it is a challenge to provide care 24 hours a day, around the clock, to people in remote settings. And I think that's where the community hospitals have always provided a great service, because they've given us that other option of bringing patients somewhere nearer their own community, but without necessarily being at home, and actually helping us to bridge the gap between the acute hospital and home. And so I think that's why they still do have a role going forward. And you know, that's why there are still beds out there in all of the other hospitals in the proposals. And that's why we're talking to the community up here in Alston around how we could go about providing care for patients in some sort of facility that perhaps isn't just solely a hospital, but perhaps brings things together with the social care side of things, so that we can do something that delivers the same, but it's perhaps done in a different way that perhaps gets us around some of the challenges that we've got around the staffing, etc. So we're looking for the innovative ideas that actually will allow us to deliver the same, because I recognise, I mean, I've been a GP for a few years, I've done chalk out of hours, I've worked in the middle of the night, and you know, the services in the middle of the night, if you don't feel safe to leave a patient at home when you visited them, you don't leave them there, you tend to have to, you know, feel that you've got to send them back into hospital, and that's not ideal either, nobody wants that. So we do need the services to function safely in the community so that we can manage people in the community and they can be looked after well. Beds are one part of what we need in the community. I think there was the figures in the study the studies that compare us with other areas suggest that Cumbria as a community should have around 84 beds in its system overall. In the north of the Cumbria there should be 84 beds. The proposals recommend 104, and I think that's a reflection of the geography. And I think even looking at that, we recognise that there are communities like Alston where, you know, actually they're geographically still removed from where those beds are. So I think that's why we need to think about other ways of delivering service that actually meets the needs, but is maybe different to what it is now.
So if I can just interject, for the record, the question is that we need beds there. And I would ask, please, if you hold it until you get the microphone so it's recorded in the evidence. There's a lady here who's been waiting very patiently, and I'm sure we're going to return to these questions, but I want to give everybody the chance, and then I'm going to come round this way, and I will return. Okay, so there's a lot of hands and a lot of people who wish to speak.
Thanks. I'm Jane Mays, and I lived here over 40 years, and I work for the End-of-Life Care Research Group in the Free University of Brussels, which is world recognised. Now, you've come to learn about Alston and to listen to us in Alston, and I think you've picked up most things. Although it came from Mr. Murat in Brampton, the last point was a very good point. You've heard about how long it might take to get round to Penrith, etc. Brampton and Wigton are only 10 miles from Carlisle, which feels very, very different from here. You've heard about, you started off by being lucky enough to witness that huge welling up of passion, of love, I would say, towards Francis and Keith. Now, that is unique. That is Alston. It's not the first time I've been to a meeting in this room where people have expressed that towards Francis and Keith. I mean, it had me in tears. I don't know what it did to them. So Alston is different. And as you've recognised many, many times, but yet on that document, in all your options, after 6 months or whatever it is of doing consultations like this, pre-consultations or whatever you called them, Alston is still out in your document. Now, it's very easy to slip from that. It's the preferred option, which means closure of Alston Hospital. Let's not beat about the bush. As Mrs. Dugdale said, a hospital without beds is a clinic. It's very easy to move seamlessly from that as being your preferred option to being the reality. I'm very sorry, but... And then there's all these sensible things about recruitment and money. Money, I mean, that's the whole point. But what I want to say that you haven't heard about Alston here in this meeting, and you may not know it, is what a perfect example of best practice in end-of-life care that hospital is. Just one more point. It's not just for end-of-life care, the hospital, I must make that clear, but that is absorbed into the Alston plan by Dr. Crick and Malcolm Forster, which you're aware of, and it would also could be absorbed into the ICC, the Integrated Care Community, if that had time to be developed. Now, as you know, the County Council, which would play a large part in it, would have to cooperate with and the NHS would have to cooperate with that. Is only just beginning its own consultation process, which is going to be much more thorough than yours, I understand. But they've always had in mind the chance to do what you could do as well, to be able to say, Alston, we've got the gem there, we've got the best practice gold standard of integrated care. Why destroy it? It's here now in end-of-life care. It could be here in integrated care after this process is over. Not if you knock it out. If you knock it out, then the county council has got no, and the NHS has got no opportunity of building that integrated care. We need a new care home that's below standards. That could move across the road to the hospital. The hospital, I'm not totally sure of the hospital land situation, but that did belong to the people of Alston before the NHS was created. It's not really up to managers and clinicians, and I'm not being rude to managers and clinicians, but it's not really up to them to give away Alston's unique possessions, unique character, destroy it, because it doesn't quite fit into the 184 beds or the 20,000, etc., etc. I think I've made my point there.
Thank you. Thank you. Okay.
I agree in many ways. I think that, yeah, but what I think, I agree, Alston is unique. I think success in terms of a vibrant future for Alston actually comes from you as the community telling us what you think would work for you, and I think that's what I hope we'll be doing. And Claire Malloy, who's the Chief Exec of our trust, came and met with some representatives of the local area after the consultation was announced, and we're very keen to work with you to do what we can to look at how we can solve this problem in a way that works. So that actually the social care side, the care home, for instance, we include that in the mix. The general practice needs to be included in the mix. All of the services need to be included in the mix. There's lots of services that the community probably delivers to itself, like the ambulance service, which actually all lean on, but all the services, I won't list them all, but they all lean on each other, don't they? They're all interdependent. You take away one, and you recognise you destabilise the rest, and I think that's what has been alluded to several times. So I think we recognise that having something that functions for the community is absolutely important, and we completely get that, and we'd love to work with you to deliver it and come up with a really innovative solution. And this is a consultation process. All the things you're saying tonight, all the things we're saying back to you are being recorded and will be fed into that and will help to feed the outcome. So I think it's really important that you say all these things because it's right.
Sorry, well, just wait until the microphone comes.
If that's going to happen, and Claire Malloy has said in public, on the record, that Alston was chosen because it has an old building that needs things doing to it, put Alston back on that options list before you start doing whatever it is you're going to do when this is over. Otherwise, we've lost it. We've lost it at this point. We all recognise that. We know that, don't we? That decision has already been made, and you're just being nice.
Yeah. Can we absolutely point? Can we let the response?
Let me reassure you, and as I said earlier, we welcome alternative proposals because we don't believe necessarily that we've thought of everything. So if there is a viable proposal that comes up with, and you've highlighted it there, madam, this combination of care and alternative uses for beds relative to the care home that is in need of replacement, then that is an option we would take very seriously. So just because it isn't there at the moment in the consultation document doesn't mean to say that the clinical commissioning group wouldn't seriously consider an alternative proposal.
Sorry, can you wait until just wait, we'll get the mic to you now. You're calling a point of order. Yes.
Sorry, it's just occurred to me, if the option here that's preferred is without us, you're putting this round to the whole of Cumbria. Everybody's going to give the preferred option without us. We're not even on here. This is out of order. This is completely out of order. We're not even on here. And you're asking everybody in Cumbria to fill this in. So they're filling it in without us.
Okay, thank you. Point noted. We have a lady down here been waiting very patiently.
My name's Sonia Kempsey, and I've lived in Alston for around 40 years now. You say that you have a vision for a centre of excellence for integrated health and social care provision in rural, remote and dispersed communities. So it's totally illogical then to downgrade community hospitals. On the contrary, I think this presents a case for rural community hospitals to be at the heart of rural communities and expanded, not contracted. Elderly populations are increasing, and we're talking about integrating health and social care. So why not expand the number of beds in Alston, not contract it? The other thing, on another matter, you've mentioned the idea of creating new partnerships. And if we want to have an innovative and really special provision that we can act as a sort of a beacon for other people to follow, then we could be looking at possibly working with across administrative boundaries. We've got people in rural areas in Northumberland and Durham, several very small communities which are closer to Alston than they are to Hexham or Haltwhistle. And similarly at the top of Weardale, they're closer to Alston than Stanhope. We could be thinking about how can we serve those communities as well. That way we could expand our beds. And we should also, when we're looking at potential partnerships, look at possibly, if the only way forward is possible, creating a community enterprise where it could be some additional trust that helps to find additional funding if that's required to make sure that we have the services that we need.
Thank you. Thanks very much. Okay. Who on the panel would like to respond to that call for more innovation and partnership?
Sorry, say again.
More innovation and partnership.
I agree. Yeah, I think that's what we'd like to explore. You know, as I said in the previous answer, you know, the future of all of our healthcare, all across the county, everywhere, including Alston, is about the community taking some ownership and helping the people who are tasked with running the health service to run it effectively to meet their needs. And I think, you know, the more the community gets involved, the better. And I think a lot of what you said has merit. So,
sorry. Okay, so just to repeat it so the rest of the audience can hear, it's to bring to the attention of everybody the point of order point that we're consulting on options which doesn't mention Alston, and the rest of everybody else that's being consulted on this could vote for it. So I think we'll take that point.
Yeah, yes. The strength of feeling in Alston and Wigton and Maryport when it comes to the proposals for community hospital beds means that it's going to be impossible for the clinical commissioning group to ignore those concerns, despite the fact that other parts of West, North and East Cumbria may not see those beds in the consultation document.
Okay, there's a lot of frustration. I know a lot of people have had their hands up for a while. So we've got a lady at the back that's been waiting for some time, and then I'm going to come across to the two people who have had their hands up for some considerable time. So the lady at the back there, please. And then I will come back to you. And I will come back to you, sir, as well.
I'd just like to put a couple of points to the panel, please. After the meeting on the 28th of August, my mum wrote to Sir Neil Mackay.
Could you hold the mic a bit closer?
And handed a letter personally to him. She had no reply. She wrote back to him on the 30th of September, after receiving a letter from the Ministry of Health, and still had no reply from Sir Neil Mackay. They actually advised her to write to Health Watch Cumbria. She's had no reply from them either. Interestingly, my mum then wrote to Theresa May, and on the 29th of July, and had a reply on the 20th of September from the Department of Health. I'd like to share with you a paragraph from this and ask your opinion on it. The NHS in Cumbria has made clear its commitment to developing a strong and sustainable clinical strategy for healthcare services. The aim set out by the Success Regime programme is to enhance and expand the range of services offered to patients in community hospitals, not to reduce them.
Thank you. And I think that reflects the the proposals to bring more services out of the acute hospitals, to deliver clinic services, to deliver outpatient services and diagnostic type services nearer to people's homes. So hospitals deliver lots of things other than just beds, and I think that statement reflects the intention to do that.
Thank you. I've got a question from, I'll take the lady here first, and then I'll take your question. Because they've been waiting longer.
Hi, I'm Sue Carlton-Dunn. Some of you might know me. I'm a relative newcomer. I've only been here 17 years. Moved up here from London, used to work in the NHS, moved here because it was a great place to bring up a family. If I was making the decision today, I would not come here. People need to think outside the box. Doctors, consultants don't want to come here because there aren't specialties. Make an arrangement with Newcastle. Have a rotation. Oh gosh, it's another health authority. Does that make it difficult? You've got to talk to people, not just in Cumbria, but outside Cumbria, and have a working system. The other thing is bed blocking. I know nobody's mentioned bed blocking, but it happens, we know about it. Patients in Carlisle, gosh, isn't this a wonderful place for convalescence? Don't close the beds, increase the beds, and transfer your patients from Carlisle who still need hospital care but don't need the acute care and can't go home, bring them here. You know, there must be dozens of people in Alston who would come in and visit patients who weren't even related to them, because that's the sort of people that we are. And okay, you know, I wasn't born here, but I count myself as a we. That's what we're like. Take advantage of that in the nicest possible way and bring the services here. Wonderful place for convalescence.
To pick up the final point first, the patients do come up to Alston from Carlisle and from other areas. Unfortunately, not all patients find that a very easy thing to do because their relatives can't come and see them, and obviously it takes them out of the community. So that's why, you know, having a bigger unit in Alston would probably not work for that reason, because there isn't the size of the population to justify that. But I take on board your point, though.
Yeah. Okay. In a minute, we'll come back to you. I've seen you, and I'll come back to you. Just allow the panel to answer these questions, please.
Coming to the issue of trying to forge links, yes, we are trying to forge links. In particular in the field of oncology, looking at getting a very strong linkage with Newcastle. Oncology, like a lot of specialties, is getting more and more subspecialized, different areas, and it is one of the difficulties that Cumbria faces, is trying to provide all the subspecialist services that a population requires to a relatively small population. We're quite unusual that as a DGH serving a population of 340,000, we have a huge range of surgical specialties, each which has to be covered independently. So if you compare us to Northumbria have got general medicine, trauma orthopedics, maternity, general medicine, and a modest amount of pediatrics. That's the entirety. Whereas we've got ophthalmology, ENT, maxillofacial surgery. We've got a range of medical specialties that Newcastle would provide rather than Northumbria. With a large number of specialties, we have to cover every one of these. This gives us problems. We end up with relatively small departments, and you have a very frequent on-call, which becomes quite difficult to make attractive to somebody who fancies being on a 1 in 7, 1 in 8, rather than a 1 in 3. So it gives problems, but we are therefore trying to forge links. The other major bit of work that's being done that way is to try and forge just the sort of link that you were saying to Newcastle on the paediatrics and see if we can find there is some mechanism by which across the Cumbria and the northeast we can try and get a network of paediatricians and make the whole the job and the prospect of working here more attractive.
Thank you. I will come back to you, but I've got some people over here who've been waiting. And the gen there, please. So there. Yes, yes, please. And I will return to your questions, but I'm coming this way after that.
Yeah. This question is a little bit tangential, but about the school student outreach. I'm terribly sorry, I forgot your name. But it's mentioned a while ago now.
Sorry, you're talking about Anna?
Yes.
Yes, Anna, yeah.
Yeah, about getting more students interested in medical things. When did you start this?
Is this the nursing training?
Yes.
So the Partnership Trust have been doing this for about 2 years now. And they've been working with local schools. I don't work for the Partnership Trust, so I can't tell you exactly which ones. The Hospital Trust have been working in the last year only. I came into post just over a year ago to try and support the transition into an excellent organisation. And I started the work just over a year ago around liaising with the local schools in Carlisle, because I'm obviously, and Whitehaven, because I'm trying to bring students into the acute trust, and working. We have set up the cadet scheme in both Carlisle and Whitehaven, and in fact that's been running 2 years, and some of our cadets have gone on to do their nurse training this September. So the work has been going on. I'm sorry if you haven't heard about it, and I would be more than happy to give you some more information and put you in touch with people at the end of the meeting if you are interested.
No, I was just saying that Samuel King School hasn't heard a thing about this. Like, as a former student, like last year.
Yeah.
Anyway.
All I can do is apologise, and I can ask that the Partnership Trust education leads get in touch with Samuel King School.
Okay, so thank you for the question. I do need to move around. Got a lot of people. Bring it to the gentleman here. A lot of questions, and I will come back and try and get everyone in. Just one cry from the heart. We've got a little bit of time, so if you can make the questions as brief, and also the panel make your responses as brief as possible. Don't want to limit free speech, but I want to get us all the questions in.
Thank you. Mark Nash-Williams, Vicar of Alston Moor. 3 things very briefly. First of all, you've said you'd be happy to consider new imaginative approaches, but there was a brilliant one put forward in the Alston plan. It was mentioned in your draft document, so Neil Mackay said it was inspirational, and it hasn't appeared in this one. Why has that disappeared? First question. Second question, you've talked about how all the services on Alston Moor are interconnected. That goes, I think, further than you may realise. I've had young families already saying to me, we've got children with particular needs. If we lose a 24-hour care here on Alston Moor, we will leave because of their concerns. If they go, the schools have become vulnerable and the rest of the community will suffer. It may not just be about the loss of the beds or the hospital, it's about the loss of the community as a whole. Third thing I'd like to reiterate what Jane has said about the quality of the end-of-life care here. I've known people in the Cumberland Infirmary desperate to get home in tears, saying, I want to go home to die. And by home, they meant the Alston Hospital, because that feels like home, because they know it from the day hospital, from the care, they know the staff. It's a wonderful place to die. There's no better end-of-life care, and if you lose that, you're losing something very precious, which the National Health should be supporting. Thank you.
Thank you very much. Who would like to respond first? Craig, yeah?
Thank you for those comments. I think you're right, the end-of-life care is excellent in Alston, and, this is a challenge for all rural communities, isn't it, is that if they're eroded by services changing and leaving and moving on, that actually what the community is left without some of the key things that make that community what it is. So I think I agree. So I think we recognise that. I can't comment on the option that you mentioned, though. I'm not able to. I don't know whether Stephen knows anything about that.
I'm talking about the Alston plan, which Jane mentioned, which the Friends produced, which Sir Neil Mackay has seen, which was in your last consultation document, which talked about integrating hospital care, social care, the residential home. It's all in there.
Thank you.
Sorry, I didn't recognise what you meant by what you said. That. So yes, I do understand that. And I think that those thoughts are along the lines of the conversations that we're having currently with the League of Friends and the community around the alternative options. So I think that I can't answer that because I didn't write the document, but we are considering those things now. So.
Okay. Right. Okay. This lady here. There's a gentleman at the back of the rolled up paper we're going to take, and then there's another gentleman here. So, and then I'll try and get to everybody that I can. Okay.
Thank you. This gentleman just now preempted what I was wanting to ask you quite urgently, as you could tell. I feel as though we've been hearing a lot of flattering and empty remarks from you, sir. I know you're a GP, but perhaps 2 or 3 responses ago, you said something which I found very disturbing. I think it was to this lady here. You basically seem to imply in your comments that you'd already made up your mind, that there was no point, how did you put it, in making the cottage hospital larger. Well, I'm not sure that she was saying that specifically. She was trying to be creative in terms of making it more viable. You immediately said something like, well, there's no point in making it any larger, it won't work. And it did feel very much to me as though you've already made up your mind, no matter what you're saying to us. The other thing that's troubling me very much about this whole hour and a half or whatever we've spent here is that we're all discussing the difficulties, the challenges, the financial mess that the system is in. But we're not approaching this matter from a constructive point of view, and so many people have raised marvelous constructive points, some of them creative, some of them practical, some of them financial, and it seems to me that none of those are being grasped upon with any real intention to work on them. You yourself mentioned a little while ago that you had been in touch or communicating with the League of Friends. You only mentioned it lightly. You didn't give us any information about that contact. Certainly no content. Now, perhaps this isn't the right venue to do that. But I'm very disturbed by this because, again, it seems to me that you are writing off this community, this cottage hospital, the beds, the whole works. Excuse me, I'm American. Forgive me because I know it's a great sin in this country to raise your voice. But I do feel, perhaps if we were in Scotland, I could do it. But I do feel that we're not really getting to the nitty-gritty here. And Mr. Childs, is that your name? Mr. Childs very rightly said from the start that we should be here to be considering real ideas, perhaps creative ones, perhaps things that will involve a little work to accomplish because they're irregular, as this lady here suggested and many others have suggested, that we look outside of the boundaries. Why are we being made to conform to your financial budgets when perhaps there's something that NHS, the social services, the voluntary sector, doctors and nurses themselves, creative thinkers could pull together? And that's why what I'm really wanting to ask you is, if you have indeed consulted with the League of Friends who are trying to preserve this cottage hospital, and you've heard how much it means to all of us, and if you are not trying to write us off with all of this placating presentation, much of the beginning of it could have been, as far as I was concerned, much shorter. Anyway, if you're not trying to write us off, can you please give us an indication of when you will look at this proposal, or have you looked at it already? And can you help with this proposal?
Okay, so welcome the passion. Get to the questions.
Thank you for your comments, and I apologise if I haven't come across as sincere, because actually that's not the case. I am very sincere about what I'm saying. We have met with the League of Friends and representatives of the community, and I'll ask Malcolm to comment on that in a couple of minutes. We've been up for 2 meetings, and we're in the middle of writing a document that actually pulls the proposals together. So absolutely we are committed to helping the community come up with the solution, the constructive solution. Yeah, so this is happening. What I can't do, what I can't do is promise you that, that whatever's in there will happen. What we can do is submit it to the consultation process and allow it to be considered and given due consideration and being given consideration on its merits. Because if it's as good as I think it could be, it should be considered on its merits, and it may well stand up to scrutiny, and that would be great. Now, nobody will be happier than me if we kept the services in Alston with beds, working in an integrated way, and delivering services to the community. Nobody will be happier than me.
Sorry.
We already have. So I've met with the League of Friends on.
Sorry, can you just wait till the microphone, because it's not getting recorded. It is, but I want to get it on the record so we understand
Certainly,
what. Yes,
I'm sorry.
that's fine.
Okay. So the reason you haven't heard a lot about it today is because actually the plan is not yet in a state in which it's ready to be presented to a wider audience. It's still being in the process of worked up, and I think in order for it to be considered seriously, it has to be in a state where it's actually ready to be considered by people and scrutinised.
Can you give us some indication of how long that might take? How far along you feel the plan is? What perhaps are its weaknesses? Is there anything the community should be addressing?
Okay,
sorry.
Can I just cut across there?
Sorry.
No, absolutely brilliant points. We're getting into some real detail. I've got a lot of people who want to answer some questions.
We would like to get to some of the nitty-gritty in this evening. We've all come here this evening wanting some real information, not an overview of things that most of us here are already aware of, perhaps not in as much detail as you presented.
Can I just ask you to allow the panel to speak, please?
We are already aware of the things you've come to present to us today.
Yeah, okay.
Our concern is such that we are already aware of these things.
Thank you very much. Can you get to answer the question quickly, because I want to bring other people in. Thank you very much.
Could I ask the gentleman who gets the microphone to take the microphone to Malcolm over there in the audience, who can answer some of your questions for you and actually confirm that we have our conversations and we are working on it, because I think that will probably be the best way of answering your question.
Malcolm Forster, League of Friends and North Cumbria Joint Leagues. You'll recall that Dr. Crick and I wrote the Alston response paper to the original proposals, which put forward the concept of an integrated health and social care facility with flexible beds that we could move around for use. That went to the the success regime. We have had a number of conversations with them post this consultation document, and they have in fact asked that we resubmit the plan with figures on it. Now, clearly as a League of Friends, we don't have the figures to submit, and we're very grateful to Claire Malloy and Craig Melrose for working with us on providing the figures. Most of the finance questions or numbers questions or how is it actually going to operate is what we're working on at the moment. As you can imagine, it's very difficult to tease out figures from across various parts of the NHS and then try and get them out of social services as well. However, we are hopeful and we're working on it, and I would hope we would start getting something that's meaningful in about a week, week and a half, though there will be a number of questions following on for that. The success regime would like us to put the paper in either at the middle of this coming week or the week after. That is not physically going to be possible. I'm hopeful and aiming for we can put it in end November before the consultation period is over.
So the question was, why is it so difficult to tease out these figures from the NHS?
They come from various different bodies, and clearly when you get one set of figures, that raises another set of questions. And then you've got to go back to work out which body you should be asking for those figures from. So it takes time to pull the whole thing together. It is in process, it will be done, and it will be submitted, and it will be submitted within the consultation period. I'm very hopeful, well, obviously I'm hopeful that it will actually be given due consideration. Personally, I think the savings, do you want me to answer the question on the nursing budget? All right, I'll leave the figures out. I think that the savings are actually minimal. And if the SR itself says they're modest, and I think when you actually work it through and work through what an ICC working for Alston might look like, they'll be even more minimal, because we're going to need an awful lot of feet on the ground. So that's really where we are on it. A couple of other comments. Alston obviously is in North Cumbria and falls under the success regime. Millom is in South Cumbria and falls under Better Care Together regime. Millom has 8 beds and is being hailed as a superb example. Now, that strikes me, it's a postcode lottery, but it's not only a postcode lottery, it's a regime lottery, and that's something that we want to address. For anybody who's read the pre-consultation business plan, if you look at Appendix L, I think it is, sorry, sorry, I'm having it.
So I don't wish to rush you, but I'd like to draw this to a close.
I'll draw it very quickly to a close. If you look at the travel impact analysis, the extra time given for journeys once the beds are closed in Alston is 2 minutes, 18 seconds. Now, I wonder if the panel can share with us this wonderful success regime time machine, because we'll then be able to adapt it for all the other problems we're facing. Thank you.
Thank you very much. Thank you for the passion of that question, and thank you for the depth of the response. I'm sorry, I'm going to move it on because we've got some people, at least 3 people have had their hands up for at least half an hour, if not longer. So take the gentleman at the back, then I'm going to take the gentleman here, then I will take your question. Okay, thank you. Just.
Hello, can you hear me?
Yes.
Right, I just want to say
closer?
Alston Hospital isn't just about end of life. It's excellent for that. It's also excellent for making people better. I looked after an elderly father for 16 years. He was able to have a good life because of Alston Hospital, because when his GP deemed it necessary, he could have a bed at Alston Hospital. And he came back and they made him better many times over those 16 years. Just before he died, there was the Closer to Home project came in, where they decided that it was better to keep people at home. Honestly, I do get a bit cross. We did all that we could to keep my father at home, and he wanted to stay home, but the alternative was Alston Hospital. He was happy with that. The Closer to Home thing involved adult social care, social services coming and discussing with the district nurses in the sitting room how it was difficult to share out the stuff because they were underfunded and understaffed. So nothing very much happened. I mean, I just think if you actually look after elderly people, you know how difficult it is and how comforting it is to have the bed nearby. And incidentally, whenever my father went to Carlisle, he got much, much worse very quickly. The other thing you said about people not wanting to come here, I was in a taxi the other day, and he said his mother was here 2 years ago when Alston had been down to 6 beds. He said it was absolutely marvellous. Everyone I've ever spoken to who's come here from elsewhere has said it was marvellous. So that's my bit.
Thank you. Thank you very much for those heartfelt comments. They're noted, and they'll be part of the consultation. Pass to the gentleman there.
Need hospital. Hi, I'm John Sockel. I live in Alston now. A bit of an apprentice, really, when you think about it. I've been here 2 years.
Could you hold the mic a bit closer?
Right. My question directly is this, that if Alston does lose its beds, and you have this idea of people staying at home and being cared for at home, will that involve direct costs through a social services package that many people have to pay for now in their elderly years? So from a baby up to retirement, are they going to have to pay directly for this service at home rather than free at the point of access to our hospital?
Okay, a point well made.
The way it works elsewhere is that if you're looked after, for instance, by the hospital at home service in Carlisle, that service is free, and you receive the care that you need for the acute part of your illness. If your needs change and it becomes the situation that you need ongoing social care, ongoing help with things like dressing, washing, and preparing food, etc., well, there are, as we know, charges attached to that because that's how social care works. Ongoing nursing care, though, doesn't get charged for, so there is an assessment done around how that's funded and paid for. So that's a continuing care process. So yeah, in the acute phase, and when you're acutely ill, your medical care and nursing care is continued to be provided by the NHS.
Sorry, and the comeback statement was that could change at any time if you haven't got a hospital bed.
No, I was talking about the hospital at home service in Carlisle where that care is provided in your home. So that's out with of the hospital bed, yeah. No, that service isn't operating up here, that's right, because it's, as I say, that's a service that specifically works in Carlisle. There's lots of variety across the county in terms of the different services that operate in communities. And again, that sort of reflects the needs of the community and the setting. So.
Thank you. A gentleman down here has been waiting very patiently.
Thank you.
Sorry, could you stand up so everyone can see you? Thank you.
My name's Alan Strong. My question concerns the consultation questionnaire and how we can respond to that. In the questionnaire, we're given various options, which we can select and then say why we have selected them. Nowhere in any of the questions, not just on community hospitals, but anything, is a box to say, I disagree with this. We have not got any way of voicing our disgust at the closure of hospitals. How, Mr. Chairman, you could maybe get off the panel, how we can express this disgust on this questionnaire. Because what I fear is that the various body will in the end say, option 1 has so many votes, option 2 has so many votes, option 3 has so many votes. But the people that are totally against any of the options do not get recorded.
Okay. Before I throw it to the panel, I just want to make a comment. It's very important to state that the questionnaire is not the only way that you can respond to this. So if you feel strongly that there's something not in the questionnaire that you wish to respond to, you can provide written comments which are taken with equal weight to the questionnaire, and that's assessed by an independent person. So I would urge you, if you're unsatisfied with the questionnaire, to write in, and I'll hand it to the panel to respond.
Well, I think the chair has answered the question, but not only that, but all of the comments today are part and parcel of the consultation process. So you don't have to write it down, you verbalise it, it's recorded, and that will be taken into consideration. So and please, as I said in the presentation, it's not a vote. So there's no counting up of those in favour and those against. It's the strength of opinion recorded through the written word and verbally from meetings like this, and many meetings with target groups that have expressed an interest to have a particular audience with us to air their views.
Sorry, can you just wait? I will come back to you. There are some people who've been waiting very patiently, so I'm going to throw right back to the back, then I come to the gentleman, and then I'll allow you to ask that follow-on question. Sorry, we're going to go straight to the back. Yeah, there, yeah.
Hello there, good afternoon. My name's Brian. I've just moved to the area in the last, week or so thank you very much for accommodating me. I do move patients for a living. I move patients on the patient transport service, and I've moved many patients up to Alston, of which every one of them has been grateful to be closer to home from Carlisle and Whitehaven. The response on the documents that we've seen tonight on the slides and so on seems to be Alston is being removed from the map as far as the hospital is concerned. Now, a quote from the panel tonight, the gentleman, the GP there said, we need to think about it as far as the alternative. And then also you said, we are looking for ideas. So we need to think about it, and we're looking for ideas. The alternative. First of all, the removal of Alston Hospital, but you're coming out with quotes like that. Can you comment on that, please? Thank you.
So if I've picked you up right, I think we're in a consultation process, so that means that we're here to listen to the views of the public and to take on board your opinions, which everyone has voiced very clearly to us tonight. So I think we're here to listen, we're here to hear your views, we're here to hear your ideas. So that's what I was trying to say, is that there are options in there, there are things that have been written down and sort of laid out as sort of the choices as the health system sees them. But if the public knows better than we do, that's fine. Bring those ideas forward. We'll consider them, as Malcolm has alluded to. We're talking about the ideas for Alston with the community here. Does that answer your question? Or have I misunderstood your question?
Yes, in some respects, but what's the alternative? And obviously the consultation with the League of Friends that you're having, is that actually clear? Is it crystal? Do the public know here what the alternatives are, and when will they be pronounced to the people on the ground? Thank you.
So the alternatives, that announcement will be around whatever proposal comes out of that will be made, as Malcolm said, in 2 to 3 weeks' time, when it's prepared to a level that actually means it, we can send it out there and it can be considered, and is robust enough for that. It takes a bit of time to build something up to a level that actually will be considered seriously. And it's very important that it's considered seriously. So, it will happen within the consultation period window. So this consultation runs for 12 weeks, as you know, so it will happen within that consultation window. The consideration of that option will then take place with the feedback from the consultation process and all of the other information that's been gleaned through the consultation process at the end of that. So all the information is collated independently and then fed back to the CCG, who will be then making the decisions around it. And the weight of opinion and the opinions and the ideas that have been shared here tonight will be considered as part of that.
Is this on? I'm Ian Johnson, head teacher here at Samuel King's and also the 2 primary schools on Alston Moor. If you're getting a new car, you tend to keep the old one until the new one's actually there for you to use. We have not had an ambulance here on Alston Moor since the end of August, I think, Rick. And the new service, which I hope to be part of, is not set to open until December. So we've had 3 months without our own ambulance service here on the moor. Can you guarantee, and I'm referring to page 29 in the consultation document, that the new integrated service, which you say in this document Alston is to play an important part in the hospital, can you guarantee that the beds, if they are to close, will stay open until such time as that new integrated service is fleshed out and in place? And can you further guarantee that it will also have some hospice-type beds as part of it?
So yeah, the beds, the services here would remain up and running until we had other services that were safe to pick up the care of the patients and transfer that care into that new service. So one wouldn't stop and then there'd be a gap. That wouldn't be the case. So obviously, the consultation period will run, a decision will be made, and then there'll be a planned transfer after that of the services into whatever new model that would be.
The second part of my question was, could you also guarantee there'll be hospice beds as part of that new service?
The beds in the current hospital provide end-of-life care. They're not hospice beds as such. Hospice beds are specifically in a hospice, obviously, but these beds provide end-of-life care and they're very valuable for that. So any continuation of a service which included beds would definitely be delivering end-of-life care, because that's one of the core things that community hospital beds do. Letting people be surrounded by the people that matter to them at that point in their lives is absolutely one of the key things that delivers great value from these beds.
Thank you very much. I'm very conscious that I cut a lady off who wanted to come back, if you just make yourself known yet. And also that we're reaching the end of our session tonight. I don't want to cut the conversation short, but what I'd like to do is come back and then take a batch of questions. Make sure that you got your hands very prominently in the air for this last batch of questions, and I will make sure that we take them and I get the questions answered before we close the session. Thank you. So, the lady here.
Sorry, I'm Helen Belger. I was a GP here and I've now retired. But I just wanted specific information about who exactly will be analysing the report independently, and is there any right of appeal at the end of that? And could I also just make a kind of personal comment that really the service that's provided here at the hospital has been quite amazing, and I do see it in rural areas that services are withdrawn. It becomes much more difficult for communities to support themselves, and I just think it's something that needs to be supported.
Thank you.
So in terms of the independent assessor, you wouldn't expect the CCG to be involved in the appointment of that independent assessor because of their independence. So the success regime is arranging for the independent assessor to be commissioned. The decision on receipt of the findings of the independent assessor is made by the governing body of the clinical commissioning group. The governing body is made up of lay members, GP clinical leaders, and some of the directors, the executive of the clinical commissioning group.
Okay, thank you. Right, last questions. Can you please make sure your hands are prominently up? So we've got 3, 4. Make your questions very brief, and we'll take them as a batch with the panel. Okay, so we'll start at the back there. Keep your hands up so that we don't get lost.
Hi, Jeff Rogers. Before I retired, I worked for Cumbria County Council. And I'm interested to know where you're going to get your social services people from, because Cumbria County Council have been gradually reducing their social services, both on adult social care and children's services, over the past 4 or 5 years, due to cuts in funding from government. So the people that are left are having to shoulder a bigger workload, and they're going off with stress. So where are you going to get them from?
Okay, thank you. Adult social. Hands. So we've got a hand over there, please. Keep the questions as brief as possible, please. Sorry, can you hold the mic close to your mouth, please?
Okay, you can hear me now?
Yes, thank you. Thank you very much.
I've been here about 30 years, and that hospital was a help from a mother and many of the elderly people. But it's also been a help to young people. This community is much more than the elderly. We have one preschool. We have a lot of babies. And we have 3 schools. And the headmaster has already said about the lack of ambulance. This hospital had 20 beds until a little while ago. And it looks as if it's almost systematic. Oh, you've only got 6 beds, we'll close them.
Okay.
And then we're told there's very little stroke care in Cumbria. And for all of us, it doesn't matter what age, we can be vulnerable to a stroke.
Fantastic.
We need care, and we need doctors to work. You think this hospital had 20 beds not long ago.
Okay, sorry, I don't want to cut you off.
So my name is George Mullard, but all I'm saying is there's more on this mall than just elderly people.
Thank you very much. So, point well made. Thank you. 2 questions at the front, and then I'll throw it back to the panel. So, lady here.
Thank you very much. I'm Mary Robinson. For those who don't know me, I'm County Councillor for Alston and East Fellside. Where do I start? Right, I've been wanting to speak for about an hour, so bear with me, please. One of the governors at the acute hospitals in Newcastle has been giving me some information on various things that I've found of great interest. I have been told that there's £10 million paid per year to the Northumbria Trust. Can you tell us what we get for that £10 million? A little bit of that would fund our community beds here in Alston. The other thing that I would like to know as well is, why is it just that you just say, right, we're going to cut? Why don't you make a business case to actually get more budget into Cumbria? It's rural, it's sparse, it costs a lot more money to deliver services. The government already gives us money because it costs more to the county and district councils to deliver. Therefore, it should follow that the business case actually looks at what it really does cost to deliver sparse services and not cut the sparse services. I'm quite interested also about the beds and the 8 beds, which is, I think it's 6 or 7 in Alston, and how they're not going to be particularly safe. And if I go to the consultation document, on page 28, what you're actually saying is, the Institute's guidelines, and these are guidelines, recommend 1 registered nurse for every 8 inpatients. And we believe we should have a minimum of 2. You believe. We do not therefore think it is feasible. When you turn to page 31, you've already made up your minds, because you're saying we've explored the possibility of configuring 104 inpatient beds across all 9 sites, but have concluded this is not a sustainable option. Go back to the success regime and tell them to start and look again. We have 15 to 19 or 20 million visitors who come into this county. If you look at the amount of VAT that goes into the government, the amount of business tax that goes into the government, on the back of Cumbria, we're not funded our health for the amount of tourists that come into here, but the amount of money the government gets back out of Cumbria for the tourism, I think a little bit more should be coming. And the success regime should also start and look at perhaps looking at a different plan. And, Craig, for you, how many incidents are there on record to substantiate the conclusion it's not safe to operate under 16 beds in any of our community hospitals? And what I'm going to say is, the only time we see people in power on Alston Moor is when they propose to cut services. Don't cut and run.
Thank you very much. Last question.
Thank you. Thank you. I think the point was very well made at the side here, that we've been given options to vote on, and the people who tick boxes for each of these options will have those votes counted, and the people who write in and put in other options will be lost in the quagmire. They won't be able to be counted and calibrated easily as the tick box ones will. Now, I had the job, you won't like to hear this, I had the job of going round distributing the Alston says no notices, which you've seen about, protesting against the proposal to remove all the beds from our hospital. You say, we're going to have a better hospital after the beds have all gone. Well, I can tell you, my dictionary says a hospital is a building where sick and injured people are lodged and given medical treatment, not a health centre where there is no beds. So you're misusing the language and twisting it there.
Thank you.
Never mind. I went around distributing these notices. I never found a single householder anywhere who was not on our side in keeping the beds. I've never known a community or group of people like we have here, so completely unanimous on one thing. And despite what boxes you make, it ticks on various options, knocking out all our beds. That is the central theme, and I hope you've got that well registered. I'm sure you have.
We have,
Thank
yes.
you.
Yep. Thank you for all those heartfelt questions. I apologise for people who have not had the chance to speak. I do need to draw it to a close, but the panel aren't leaving, so if you want to talk to them afterwards. But before I throw it back to the panel, on the question around the questionnaire, it's just been pointed out to me that there is a tick box in there that says, if you have other ideas, tick here and please enter them and they will be considered. So ensure that you do that as well as everything else. Thank you. So hand it back to the panel. So.
If I pick up the financial question that was posed, I'm not a finance director, so I haven't got the figures to my fingertips, but you will recall that about 3 years ago there was a proposal that there be a merger between Cumbria and Northumbria, and as one of the preliminaries for that to happen, certain services between the two trusts were unified, and I think that might be one of the sources of the monies that the question in second row was referring to. However, given that that is no longer the option on the table, gradually that umbilical cord is being cut, and those support services to do with recruitment and so forth have been repatriated. The second source, which is regarded as money going out from here Cumbria to Northumbria, is mostly on account of clinical services, certain specialties, especially orthopedics, where a lot of orthopedics has been undertaken in Northumbria, which reflects a lack of capacity in Cumbria. We have an active plan in place to reverse that. I'm quite sure that given the option of going in and having a hip done in Carlisle or going to Wansbeck or whatever, most people would elect to come to Carlisle if the capacity was there. So that is the plan that we're trying to get underway. What else? As far as the funding model goes, yeah, there is a thing called market forces factor, which says that how much one gets paid and the amount that it's multiplied by accounting to where you are. And if you're in Truro, you get 100, and if you're anywhere else, you get something higher than that. In London, it's about 150. The market forces factor is set up according to what local pay rates and things are. But as was articulated earlier, Cumbria is somewhat different. Of course, it's not within our powers to alter that. I mean, I think, really need to look to your MP. One of the advantages of being in a swing seat, of course, is the MP may be a little bit more anxious for his seat than perhaps if he was in a safe constituency. But the last thing I was going to say to you, though, as someone who's coming in where I'm the issue of the community beds does not sit with my trust, and I'm a reasonably, understand the word correctly, disinterested observer, right? And the impression I've had tonight is that you have articulated your case very well, right? And I would really emphasize to you that much as it's easy and I think quite natural to be cynical about a consultation exercise, I really do say to you the best thing to do is really engage with it. Right? I do not, I'm afraid, agree with you the idea that writing in and so forth will just go lost in the morass. This is a proper exercise, and I have seen occasions in which it looked like the tide was flowing one way, and the opinion, the consolidated opinion of the population made the tide flow another way. So I would engage with it. You feel strongly about it. I'll get you all. I would really encourage you to write in and express your opinions.
The question about where the social care resources come from, it's a very important point. Social care has seen more drastic reductions in its funding than health, and we know that councils up and down the country are finding it incredibly hard to meet the needs of the populations they serve. Left on their own, if we were to do nothing, that problem would become harder and harder. So the West, North and East Cumbria system, that's health and social care, are coming together to try and manage the totality of the resource to ensure that we spend it where there is the greatest need. And the idea of the integrated care communities is to try and reduce the demand on secondary care, hospital services, so we can invest more in the community, and in that way we can finance more social care. There will be a need to invest pump priming funds to get the integrated care communities off the ground, and we have put a bid in to the government for £4 million a year for the next 3 years. It's short-term funding, but that's the level of resource we will need to kick-start these integrated care communities, after which they will need to be self-sustaining. But the important thing, as a community, as a system, we understand that we need to manage the resources in a different way and not leave them locked into individual organisations. And I'll just pick up the lady's point about revenue, revenue coming into Cumbria. It's not lost on us, but it's not in our gift to demand from the government that some of that revenue comes back into Cumbria. And I guess, Madam, you're in a better place to lobby for that than we are as public servants.
Just to pick up on your point about the safer staffing numbers, the ratio of one trained nurse to 8 patients is something that follows national guidance, and it was adopted 2 to 3 years ago as being something that we would, as a trust, aspire to deliver the highest quality of care to patients, and therefore thought we should follow, as it was national guidance around that is the safe ratio. Yep. Well, yep, no, well, I agree, but we should aspire to deliver care that is as good a quality here or better quality than anywhere else in the country, and the guidance tells us that's what... Yeah, that's right. But so in extreme... Okay.
Sorry. Yeah. I think you've made the point. Can we just let the answer... Yeah. Yeah. So... Fantastic passion, point really well made about the difficulties of dealing with things in this unique community. And I hope it's not lost on the panel. It's certainly not lost on me. But
yeah, so we're judged on our services by the CQC. We obviously have to deliver services in line with what's expected and in line with national, with our peer organisations nationally. We do flex on that when we've had issues with staffing. We do sometimes look at the acuity of the patients on the ward, and we sometimes will keep beds open with a slightly lower staffing ratio, particularly overnight, if that's the right thing to do. But it very much depends on how ill the patients are on the ward. So we do approach it in a flexible way, and we've had to, in order to keep all of the cottage hospitals or the community hospitals open across the north of Cumbria for the last 2 or 3 years. That flexibility has been essential. But I think we would all aspire to delivering the best quality care, and we have to follow national guidance, really. So in terms of are there any adverse incidents associated with a lack of staffing, I can't comment on that because I don't think it's been running for the last 2 or 3 years. Before that, I don't know whether there are any that actually attributed to a lack of staffing, but that's because I don't know that off the top of my head, but we could look into that.
Thank you. Any last comments from the panel? No, thank you. Sorry? Okay, one last question. What's happening with the Alston ambulance? And then I'll close the meeting. Thank you. Yeah.
Yep, we're working very hard with everybody now to get that vehicle back in place and up and running for the community. Yes, we've had some delays. I'll put my hands up to those. They're not mine alone, but we have had some instances that we'd need to deal with to make sure we can get things right so we can get it running correctly. We are now in a position where the estate's work is nearly finished, and the vehicle will be sited shortly at the cottage hospital. From that point onwards, we'll then be in a position to go live with the first group of people who've volunteered, and our second group will be undertaking their training shortly after the new year. So once that's done, we can then get the full cover in place for you back on the moor. No.
A date, the question was on a date to go live.
Honest answer, no. Once our first cohort are at a point where following some additional clinical training, because it's been some significant time and delay in getting the funding through to get everything sorted out, that they are comfortable to be on the road, and we're providing that training for them on a weekly basis every week. Then, with working closely with them and with their agreement, we will then get that first cohort live. And we're working towards, hopefully, the start of December, but I'm not going to stand here and give you an exact date, because I want to work with the community and the team that are going to provide that service to make sure that it's the right time that we do go live with that.
Thank you very much for that response. I've got one last note that we haven't answered the question about the costs of establishment at Alston that was asked earlier.
Yeah, I apologise. I had a bit of a brain freeze when the question was asked. We spend roughly £500,000 a year on the nursing in the community hospital, and there's about another £200,000 worth of running costs on top of that. So those are the costs. And of course, if the community hospital were to be shut, that would be in large part reinvested into other services and be used for other things. So.
Thank you very much. I wish we could bottle the passion in this room. It was a really useful set of debates. I hope you take on board the fact that the panel have taken all your comments on board. Please contribute to everything else through all the other medium that's available to you. The panel aren't leaving for a little while, so if you have some questions to ask them directly, please do. But with that, with my thanks and the thanks to the panel, I'd like to call a meeting to a close. Thank you.